Well, the primary reason being is that because of the fact that you are not, if you're getting them massive amounts of oxygen, so they're usually limited to 2 liters of oxygen. If you're giving them a lot of oxygen, it takes away their drive to breathe. So they're really restricted to about 2 liters. If you're giving a COPD patient more than 2 liters of oxygen, not a good sign, okay? Because you're taking away their drive to breathe. When you take away their drive to breathe, that basically means that you are stopping them from getting rid of that CO2. And that CO2 is going to eventually get trapped, and it's going to lead to respiratory acidosis, and then it's going to lead to things like respiratory failure. Remember, chronic COPD is really divided into what they call chronic bronchitis and emphysema. So you have a patient with chronic bronchitis, remember that it falls under COPD. So you could have COPD with primarily chronic bronchitis, you could have COPD with emphysema, or you could have COPD with a combination of the both. So when you have chronic bronchitis, remember itis stands for inflammation. So this is where you have inflammation plus sputum production. So inflammation is going to happen plus sputum is going to be produced, which means that you have two things sort of blocking your ability to breathe. Think about a lot of mucus sort of building up in the bronchus or the bronchi, which is basically the tubes that are where you're getting oxygen in, right? And then with emphysema, on the other hand, this is an issue where you have air getting trapped within the alveoli. And just to sort of give you guys a breakdown, right, of the respiratory system here, which let me pull up a picture really quickly. Okay, so when you're sort of looking at just your respiratory system here, okay, I'm just going to show you a picture right here. You've obviously got the trachea, right? The trachea is going to be really coming attached from your mouth all the way down to your throat and then down to the trachea. So air is going to come in through your nose and your mouth, and it's going to go into the trachea. And then the trachea, as you can see, branches out into these little branches here, and that's the bronchi. So this is the right main bronchus, this is the left main bronchus. And then this bronchi further divides into smaller branches called bronchioles. And the end of these smaller branches are what we usually see as like those little grape-like things where they look like there's literally grapes hanging off of there. Those are the alveoli. And so when you're talking about emphysema, you're talking about air getting trapped in the alveoli. I mean, the alveoli are not functioning. They are not doing the job of squeezing air out and in and filling with air because they're damaged. So let's kind of backtrack and talk on why do you think COPD patients, why do you think COPD happens? What's the risk factor? What's the cause? Well, there's multiple causes, right? But one of the main causes is the fact that you're going to have with chronic bronchitis, especially, or excuse me, with emphysema, is that it's the alveoli is so damaged, usually from years of smoking. Okay, smokers are the biggest risk factors for chronic bronchitis, or excuse me, chronic bronchitis and emphysema. So when you look at somebody who has got emphysema, you're worried that because of this fact that this smoking has sort of damaged the alveoli, they're not able to squeeze that air out. They're not able to get rid of that old bad air with lots of CO2 in it. They're not able to get rid of it. So the CO2 all ends up getting trapped in there. So when you have emphysema, over time, these patients tend to have what they call a barrel chest. So a barrel chest sort of looks like this. See if I can pull up a picture here. So it will go ahead and it will start to expand. That chest over time is going to start expanding. And when it starts expanding, because again, they have this constant air getting trapped in here, what tends to happen is that their chest widens. So in a lot of questions that I've seen, they will ask, what is if somebody has a barrel chest, what is what they call anterior posterior diameter ratio? And this is a question where it's supposed to be 1-to-1, meaning that my measurement from the front to my back of my chest, okay, is supposed to, or excuse me, the measurement normally is 1-to-2, right? Meaning that the side measurement is usually the lateral measurement, as we call it, and I'll show you a picture that makes it a little bit more sense. So this is supposed to be the normal, right? This is supposed to be the normal measurement, the 1-to-2. This is the chest for somebody who's got a barrel-shaped chest, and it's usually a 1-to-1 ratio, meaning that the front and the back is going to be about the same. Okay, meaning the side and the back, this was supposed to be, if you measure from side to side, it's supposed to be 1. And if you measure from here to here, this is supposed to be 2. But in somebody who's got a barrel chest, the back measurement and the side measurement are going to be equal. This is not what you want. Okay, this is through years and years of somebody having chronic oxygenation issues. You'll also see that the barrel chest people are known as pink puffers, and they're known as pink puffers because they're usually huffing and puffing. Okay, but here's the thing: with emphysema, they have air getting trapped, but they're still getting oxygen into the system. Remember, there's no blockage in any of the bronchi. So if I show you a picture of the bronchi of the lungs, there's really no blockage within this bronchi because it's all the air is just getting trapped here, but they're still getting air in. So they have really not as much issue as the chronic bronchitis people in getting oxygen. So they're usually kind of okay oxygenated, right? Now, when you have chronic bronchitis, remember this area is all inflamed. It can be blocked up with mucus. So you now also have difficulty getting air into the lungs, which is one of the reasons why you tend to have them known as blue bloaters, because they're not getting as much oxygen as we would like them to at that point. Okay, so just remember that with the chronic bronchitis and emphysema, right? When it also comes to medications, right? A lot of medications that you will see will correlate with what you also have for asthma. So one of the things that people with COPD will be on is what we call bronchodilators. Okay, do you guys remember the names of some bronchodilators that we might have mentioned over the past last 2 times that we met? Any names? What's the most common one that you use when you're giving them, like if they really are having shortness of breath?
The nab treatment.
Oh, you could give them Duoneb, yeah, but what about, that's a good one. The Duoneb is going to be a combination of albuterol plus a drug called ipratropium, and it's given as a nebulizer. So for those of you who don't know what a nebulizer is a machine that will sort of vaporize medication, and then you sort of breathe it in as a vapor. Okay, it's a vaporizer. That's what a nebulizer machine is, right? So it's a combination of 2 drugs called albuterol and ipratropium. What I was really thinking about is albuterol. Okay, so albuterol can also be given if you're having sudden shortness of breath. These patients can also get albuterol. Okay, remember albuterol is also given for asthma. That is your rescue inhaler. Same thing you can give for COPD exacerbations when they're really having shortness of breath. You can give them albuterol. Okay, you can also give them the nebulizer if they're wheezing, okay, because they can have wheezing. Think about it. They can have wheezing because of the chronic bronchitis. It's going to sort of, that inflammation and that mucus is going to sort of start blocking up the airway, right? So they can give that ipratropium plus albuterol combination, right? We can also give corticosteroids, all right? So remember, guys, corticosteroid drugs are going to have what ending? Does anybody remember? S-O?
Is on?
Yeah, S-O-N-E ending. Okay, S-O-N-E or S-O-N-I-D-E, sonide ending. Okay, and there can be names such as, we can have fluticasone or mometasone, okay, or beta, or actually that's primarily not given for COPD, but maybe in your pregnancy, but usually fluticasone, mometasone, budesonide. Okay, these are the medications. Now, usually these corticosteroids are given as a combination. So as you can see on here, this is a very common inhaler that is used in COPD patients. And you can see on here, this is fluticasone propionate plus salmeterol. So this is a combination of a corticosteroid and a bronchodilator. Okay, so this is a 2-in-1. Okay, a lot of these medications will look like this. Okay, all these inhalers, usually for COPD patients, are usually a combination of a bronchodilator plus a steroid. Okay, we also have those inhalers that look like this, and I'll show you a picture. Okay, it's called Spiriva. Okay, some like Spiriva HandiHaler. This one is an interesting one. This is basically where you actually get a pill and you put it into this little hole right here, and then you have to punch the pill, and basically the patient will breathe in the powder in the pill. And you have something like this, the Spiriva Respimat, where basically you just open it and you press this button right here, and it releases the medication. Okay, 1 dose, 2 puffs daily. So the spirea respimat, as you can see, is a combination of, it's tiotropium bromide. And actually, I would say, let me see. You can get a bigger picture here. So this is actually just tiotropium, my bad. So this is just a tiotropium. So tiotropium bromide, okay, just one drug that we are giving. And so let me get back to the tropiums. We didn't mention the tropiums as much. So you have your bronchodilators, which have the OL ending, such as albuterol, salmeterol. Then you have the corticosteroids, which have the SONE ending, and then you have the anticholinergics. Okay, anticholinergic inhalers have the tropium ending. So they're ipratropium, tiotropium. These drugs, remember, the goal of these drugs is to decrease the mucus production. Remember, we have a lot of mucus, especially in chronic bronchitis. We want to decrease that. So we can give them this combination of drugs that have the tropium, such as the ipratropium albuterol or the tiotropium by itself. So these would decrease the mucus production. Okay, so 3 main drug categories that you need to remember. Okay. Also, sort of going over some of the risk factors, smoking is the biggest risk. So you do want to tell them to cut down on smoking. But any long-term exposure to environmental irritants, so think about somebody whose job is to work with like painting, like they are a paint worker. They'd be exposed to a lot of inhalants over time that can possibly end up damaging their lungs, right? A lot of people that were working in construction back in the 60s were exposed to asbestos, which was something that ended up giving them lung cancer. Okay, so and again, that happens again over time, exposure, excessive exposure, things like that, right? Alrighty. Okay. Now, when they're having a flare-up, remember people that have a flare-up, we do teach them a specific type of breathing because they're not able to take their breath. They're not able to sort of normally breathe, right? We teach them a specific type of breathing called pursed lip breathing. Okay, and if you remember pursed lip breathing, you tell them, hey, you're going to act like you're going to blow out a candle. So you're going to blow out a candle, okay, and then and act like you're smelling a flower. So it will give them, especially if they're having shortness of breath, it will allow them to sort of regulate their breathing a little bit more, that pursed lip breathing. Okay? And I'll add pursed lip breathing on here it's right here. Okay, we also want to educate our COPD patients, and this is a big one, on remembering smaller frequent meals, because the more that they're eating at one time, it is going to cause them to have a lot of stomach distension, which then makes it much more difficult to also breathe. We also want to increase their hydration because they're breathing so much, they're going to dry out pretty quickly. So increased hydration, smaller frequent meals. We also tell them to avoid a lot of triggers and allergens that can sort of exacerbate or cause a flare-up. We tell them, this is the most important thing, guys. We tell our patients also to make sure that they increase their protein intake. We want generally our COPD patients to have a good amount of protein intake because they do put in a lot of effort for breathing, and it's more smaller frequent meals that we're emphasizing as well. We want to avoid a lot of spicy foods because spicy foods are going to irritate that area, and especially with your stomach as well, or just with your kind of epigastric pain because you might have acid reflux or GERD. You want to avoid a lot of spicy foods and things like that because, again, of the acid reflux, which then can exacerbate the breathing that we're having as well. Okay, so that's what you would sort of be looking at this point. Okay, so just a kind of quick breakdown of COPD there. Right, let's jump into asthma. Okay. Asthma, when you're having asthma, remember asthma is what we call, is usually caused by triggers within the environment or allergies. Okay, I want you to think A for allergies. So when you have a patient who's got asthma, remember that it's usually 2 things. One is that they have the bronchoconstriction. Bronchoconstriction is going to be when the airways sort of close up. Okay, it's tightening. And then we have your your inflammation. So inflammation within the bronchi is going to cause, just like with chronic bronchitis, it's going to cause a lot of mucus production. Now, chronic bronchitis is different because in chronic bronchitis, you don't have the airways shutting down, okay? You don't have bronchoconstriction. You only have mucus production. Okay? In asthma, you have bronchoconstriction and you have a lot of the mucus being produced. So this is a nice little mnemonic that I have, okay? A for airways are narrow, which is bronchoconstriction. S for shortness of breath. T for tightness of the chest and tachypnea. Remember, you feel that your chest is getting tightened, and you can start experiencing tachypnea, which is increased respiratory rate. Okay? We also see the most classic type of breathing that we have with COPD is wheezing, or that whistling noise, and it's usually a high-pitched whistling noise that we're hearing. And you can hear it usually both during when you're taking in air, inspiration, and also expiration as well. And of course, there's mucus, we mentioned that. And then when they have acute asthma attack, it's usually because they have been exposed to something that they are allergic to. So it could be pollen, it could be pet hair, it could be things like high temperatures or cold temperatures. So you can have a temperature variation that can trigger it, or going up into high altitude, any trigger, okay? And triggers just doesn't have to be anything that you breathe, but it could be also things that you don't necessarily breathe, but just changes in the environment, like having increased humidity, or it's just more cold today. Those things could all trigger an acute asthma attack. So patients are really educated on avoiding a lot of the triggers because we don't want them to go into an acute asthma attack. So what medication do I use if they have an acute asthma attack?
Albuterol.
Albuterol, yes. Okay, very good. Okay. And again, what you will see on their blood work also when you do their blood work is, remember, we have different types of white blood cells. How do we kind of identify this patient is actually having maybe asthma, right? We could look at their eosinophil levels. Eosinophils are usually elevated when you have allergies. So the way that I remember is eosinophils is a type of white blood cell. It's that specific type of white blood cell that is elevated when you're having allergies. And so you would say, ew, nasty allergies, right? Because eosinophils will be elevated. Okay. Remember, smoking can also be a trigger. Having another sickness, so maybe you have an upper respiratory infection or you have the flu, that can also, again, worsen asthma or trigger asthma attacks. Strenuous activity. So if you're strenuously exercising, which this does not mean that you avoid physical activity, you have athletes or smokers who are still able to physically be active, right? What do you do at that point? Well, you take meds. So you take your inhaler 20 to 30 minutes before exercising. That's a big one. Take your inhaler 20 to 30 minutes before exercising. Do not stop exercising just because you have asthma. And then some drugs to avoid here is NSAIDs. Any examples of NSAIDs you guys are able to give me? A non-steroidal anti-inflammatory drug. It's over the counter. Any examples? Yes, Mania. Ibuprofen. Yes, ibuprofen is one. Advil, naproxen. Okay, naproxen is not over the counter. It's by prescription. You have ketorolac. So ketorolac, indomethacin. Okay, you have your ibuprofen. Okay, Advil is usually made of ibuprofen. So then you have your naproxen. So all kind of common NSAIDs that we have. Some are prescriptions, some are over the counter. Okay, so keep that in mind. All right. And then beta blockers, okay? So this is a big one. This I did not mention, but I did want to mention now because we're in this topic, right? Your drug that is propranolol, remember that's a beta blocker, you will not give to asthma patients, guys. Big one to remember. Do not give propranolol to asthma patients because it can trigger bronchoconstriction, and people with asthma already have compromised airway. You don't want to trigger bronchoconstriction. Okay? So keep that in mind. All right. So when you have an asthma diagnosis, remember that you will be monitoring pulmonary function tests, and you're educating them on how to use a peak flow meter. Okay, so a peak flow meter, it looks like this. You do get questions on peak flow meter and how to use it. Okay, this is a peak flow meter. Peak flow meter basically will tell you, okay, if how your asthma is doing. Okay, so if a peak flow meter, I'm gonna show you a picture too. If you are in the green zone on a peak flow meter, so basically what you'll do is you will breathe in and then you blow out into this machine, into this kind of thing. And what it does is that it will show you where you're at in the peak flow meter. So if you're in the green, if it hits the green zone, it means your asthma is well controlled. Everything is working. Your lungs are doing great. If you're in the yellow zone, it usually tells you that the asthma is worsening out. It's mellowing out, okay, which is a warning sign. And if you're in the red zone, it's really bad, okay? It means that you need to take a rescue drug immediately. That's what the red zone means, all right? Which is going to be your rescue inhaler. Your rescue inhaler is going to be usually your albuterol, right? Okay, so that's going to be something that we're sure going to look at. Okay, all right. Okay, so it's peak flow meter. Remember, you take a big breath in and then you breathe out into the machine, into peak flow meter. Okay. So getting back into your early and late signs with your asthma as well. Remember, early signs of asthma attack. Remember, we mentioned that you're going to be breathing very hard, like panting like a dog, okay? So you're going to see that when they're panting like a dog, they're obviously having high respiratory rate, so tachypnea, and they probably have a high heart rate. But remember that they're more likely to go into respiratory alkalosis early on, okay? And when we have respiratory alkalosis, do we have more CO2 within our system or less CO2 within my system when I have respiratory alkalosis?
More CO2.
Less CO2. Remember, if I'm Yep, if I'm panting like a dog and if I'm breathing out, remember, I'm losing a lot of CO2 in my system. So I'm going to be in respiratory alkalosis, which means my CO2 is usually going to be less than 35. Okay, less CO2, meaning I'm going to be in alkalosis. Now, they can also have less oxygen, obviously, right, because they're not getting in as much oxygen. So we can see that they are becoming hypoxic, and they're probably more agitated, more restless, and more drowsy. Right, early signs. Now, late signs, meaning that the airway, remember, you have to think about the bronchi or the bronchi and the trachea and the bronchi sort of as a tube. That tube is getting tighter and tighter and tighter. And so when the tube gets tighter and tighter and tighter, breathing becomes much more slower, right? And so at this point, late signs, your body is starting to give up. It's saying, I can't keep up this type of breathing anymore. Because remember, in early signs, you're also using your accessory muscles to help you breathe. Because your lungs are not fully functioning, or your bronchi is so tight, your lungs are sort of giving up. You're using your accessory muscles to help you breathe. And remember, accessory muscles are those muscles that are not your primary muscles of breathing. What is the primary muscle of breathing anyways? What is the muscle that helps you to breathe primarily?
Is that the diaphragm?
The diaphragm, okay? So the accessory muscles would be the muscles that are surrounding that. So you could see your abdominal muscles are accessory muscles, the muscles on your chest, like the intercostal muscles, the muscles on your neck, like the sternocleidomastoid muscle, your neck muscles. These things are all accessory muscles because they're helping pull that respiratory system because, again, your diaphragm or your lungs are not able to do that, or they're getting too tired. So these accessory muscles come into play. So when these accessory muscles are in, they're also kind of compensating. They're trying to help everything kind of help you to get oxygen, right? But eventually these respiratory muscles also start sort of getting tired. They can't keep this up anymore. So then the breathing becomes really slow. Remember, you become bradypneic. If you guys remember bradypnea. And now you're retaining a lot more carbon dioxide because you're not breathing out as much. Your respiratory rate is becoming slow. So now you start retaining a lot of the carbon dioxide. So you're more likely to go into respiratory acidosis, right? And then eventually your breathing becomes so slow that you're not getting any oxygen in. You're not doing enough breathing to get any oxygen in. And this is when it leads to acute respiratory failure. And this is a situation when you might have to get intubated or ventilated. Okay. When they talk about intubation or ventilation, right? Intubation, for if you're not so familiar and you're sure confused about what they're talking about, intubation is going to be when they put something down your throat. Okay, it's a tube that they put down your throat, and they have to sedate you. They have to give you something before they do this because obviously you're going to pull it out if they don't. Okay, they're going to put that down your throat, and when they put that down your throat, you are going to be then hooked onto a ventilator. The tube is basically going to go into your trachea. And it is going to give, and then you're going to be connected to a ventilator. So the ventilator is going to be doing the job of breathing in and getting the air out for you. Okay, that is how intubation is done. Now, intubation is done through the mouth. What if they have something called a tracheostomy? Where is the tracheostomy going in? So this is, you can see, is endotracheal intubation. It's going in through the mouth. Tracheostomy is a hole that they basically make within on your neck. And this is usually done to your patients that need long-term intubation, meaning that I can't keep somebody sedated for their entire life on a endotracheal tube. It's just not feasible. And I also can't, keep this up because the patient needs to be sedated, because otherwise, like I said, they're going to rip it out. So the doctors will go ahead and make what they call a tracheostomy, which is a hole in the neck. And they're going to be able to then put a tube in through there and then attach that patient to a ventilator. And patients will still pull it out, but it's much more stable in regards to, again, long-term needs. So they have a tracheostomy there. Okay, a tracheostomy, remember, is usually where they're going to be sort of inserted into the trachea, and it's a surgical hole that's made. And we'll talk about this in a little bit more detail, but I just want to kind of finish up asthma. So sort of going back to asthma, right? Asthma is going to be one of those things where you are kind of looking at, oops, let me see, I think I put. Okay, you're kind of looking at how do we prevent patients from going into asthma attack. So we do tell them to use maintenance inhalers, right? Maintenance inhalers are inhalers that they take every single day. Okay, and we tell them to use that because, again, we don't want them to go into this acute asthma flare-up. So that can be a combination of a bronchodilator and a corticosteroid. If they're using a bronchodilator and a corticosteroid, remember, they use the bronchodilator first and then the corticosteroid. Okay, we do that in that order because we want to open up the airways first, and then we can decrease inflammation by giving them the corticosteroid. If they're using a corticosteroid, remember, we tell them to wash their mouth out, rinse your mouth out after use. Okay, and that is to prevent thrush. Okay, prevent thrush or this fungal infection from happening, because remember, steroids tend to sort of weaken the immune system, and especially if you're taking an inhaler, it actually sort of destroys or sort of suppresses your white blood cells in your mouth, and more things like fungal infections can start building up within the system. Okay? So you educate them on that. Remember, if you're using more than one type of inhaler, say you're using maybe like 2 different types of inhalers, how many minutes apart, okay? How many minutes apart do you use 2 different inhalers? If you were to get a question about that, how many minutes apart?
Was it 5 minutes?
5 minutes, okay, yes, okay. And then if your doctor says take 1 to 2 puffs, you usually wait about 1 to 2 minutes between each puff. Okay. Remember, usually you're educated to breathe out first before you put the seal on before you put your mouth around your inhaler. Breathe out first, and then you're going to put the seal of the inhaler around your mouth, and then you're going to push and breathe in. Okay. And remember, 5 minutes between 2 different inhalers, 1 to 2 minutes between each puff. Okay. And remember that you hold your breath for about 10 to 15 seconds after you use the inhaler, so you can keep all of that medication in your mouth. You don't just breathe out. I've seen a lot of patients, especially patients, older patients and children, right, breathe out really quickly. Okay. Remember, MDIs is what they call meter dose inhalers. And remember, there's meter dose inhalers that have more of that vaporized puff. And then there's like a dry powder inhaler, like the one that I showed you with the little thing where I said they put a little tablet in there and then they crush it. That's more of a dry powder, okay, which they need to do kind of slowly. Okay. And remember, you do shake your mouth, you do shake your inhaler before you breathe it in. You do shake it, shake, shake, shake. Okay. And then you can prime. Prime means that you sort of just spray one into the air. And usually it's recommended to be primed the first time that you open it, just to make sure that you are getting an adequate amount of medication. Because sometimes in a new inhaler, when you're trying to work with it, it doesn't go at the first, right? It's like, if you guys have ever tried to open that type of like bottles, especially like I've noticed a lot of makeup or perfume or lotion bottles, they have that little cap thing where you think it's coming, but it's not coming, right? And so you want to be making sure you prime it. So you just let it into the air just to make sure it's working the first time that you open the inhaler. Okay, and that's really how you want to use an inhaler. Remember, you wait. You clean your inhalers directed, so just sort of wiping it down if you need to, and kind of washing out the mouthpiece if you need to. Remember, we can also use spacers, and spacers, you guys remember for inhalers, not sure if you guys are familiar with spacers or if you've heard about it, they sort of look like this. So they're attached to the inhaler. And this is really used a lot with kids because, again, kids don't really have the coordination to press the inhaler and keep stuff in the mouth, and they might just open their mouth, right? So this is a better alternative. So make sure that the kid actually gets some medications, to use something like this, like a spacer. You can use it, see, with adults as well, but primarily used in kids as well. And there's ones where it can directly go into the mouth, or there's ones where it's just over your nose and mouth as well, okay, with the inhaler. So these are spacers that were commonly used. Okay. Remember with asthma also, like I said, avoid those allergic triggers that we're talking about, and kind of make sure that they are not, exposed to these and things like that at the same time, right? Okay, I think that basically sums up our asthma. I do want to kind of run over some what they call adventitious lung sounds. Okay, adventitious lung sounds, if you guys remember, are bad lung sounds. So when do we start seeing these adventitious lung sounds? Well, there's a variety of causes. Like we mentioned that you could see wheezing in your patient that has having a asthma attack. You could see wheezing in a patient that is maybe having a COPD exasperation. Okay, you could see wheezing in any situation where your airway is sort of shutting down, okay, where it's tightening, okay, that's wheezing, that's a high-pitched whistling noise. The other adventitious or bad lung sounds are what they call as friction rub. Remember, we talked about pericarditis, right? In pericarditis also is when the two layers of the outer layer of your heart are sort of rubbing against each other. You could have that pericardial friction rub. Also in your lung sounds also, you could have something called pleuritis, which is where the outer layers of the lungs are rubbing together. And it sounds like, when you take two sheets of paper and you're sort of putting it together and you're rubbing it against each other, that's what it sounds like. That's like this, okay, the pleural rub, the friction rub, and that's pleuritis for you. And stridor, okay, and whenever you hear the word stridor, I want you to think upper airway obstruction, meaning think something is stuck in my trachea. And usually it could be like if maybe a child swallowed like a marble and that marble is now stuck in the airway. Or think about it as when maybe something is blocked. Maybe your larynx, which is the little waste box in your throat, it collapsed and now it's blocking your airway. So any of these things could be causing stridor. So stridor, I want you to think something is stuck there, blocking it. Stridor is usually pretty serious. You want to treat it right away, because if you don't, then this person's not going to get any air or oxygen into their respiratory, into their system, basically, stridor. Okay, and stridor is usually like like barely any air is coming in or out. Okay, inspiratory stridor just means that you are going to have more difficulty to get air in. Okay, wheezing we mentioned already for asthma. Crackles, all right, you guys, crackling is going to be what you will hear when you have a lot of fluid buildup within the lungs, which could be caused primarily by things like congestive heart failure. You're going to hear crackles, okay? It could also be things like pneumonia. Remember, pneumonia, you have a lot of inflammation and a lot of fluid sort of built up because of this inflammation within the lungs. So pneumonia is something that can definitely, you can have crackles, especially if it gets to be really bad. And this is what was happening with a lot of your COVID patients. So give you a little bit of a case study. When patients got COVID, they got a lot of inflammation within the lungs, which created a lot of mucus. So the actual lungs was sort of bogged down with all this mucus. So all this mucus sort of started damaging those lungs, right? Over time, it started creating a lot of scar tissue. And that led to fibrosis, that hardening of that lung tissue. And when that lung tissue started hardening, remember, our lungs are no longer properly functioning. We're not able to adequately get enough oxygen into the lungs. And this is a reason why a lot of these patients then went into acute respiratory failure. And with acute respiratory failure, that's the reason why they had to be on a ventilator, because your lung tissue is sort of bogged down with all this fluid, and then eventually it's going to start hardening. Once it goes into the fibrosis stage, really there's no return. Once it hardens like that, the lung tissue is sort of forever damaged, and then these patients usually are going to be on a ventilator for the rest of their life if they choose that, or if they take them off the ventilator, they will not be able to survive. So a lot of times with our COVID patients, we were trying to prevent them from going into fibrosis. We didn't want them to go into fibrosis. We just wanted to treat that inflammation. That's the reason why a lot of your COVID patients were also on prednisone oral. Okay, so sometimes what happens is that maybe the inhalers are not that strong, but the inhalers only work in your lungs, but maybe they're not that strong. And even if a patient with COPD or even asthma, if they have a very major flare-up, they're sometimes given by-mouth pills like corticosteroids to clear up the inflammation, because a by-mouth pill is going to work systemically, meaning it's going to work in the entire system. It might be a little bit better because then it can work more so on the lungs, so to decrease the inflammation within the body. So especially when you get your maybe asthma patient that gets sick, maybe they got upper respiratory infection, now it's causing an asthma flare-up or acute asthma attack. Sometimes when they get to the hospital, they'll be given some IV doses of prednisone or things like that as well, and then they're sent home with like a tablet prednisone form, and that's to again decrease the inflammation that we have. Okay, and then we have rhonchi. Rhonchi is something that you can hear, for example, in patients that have a lot of mucus sort of in the lungs or in the airway. And rhonchi can be cleared. So rhonchi, if you kind of cough and things like that, it can sort of be cleared up. Okay, it's sort of a low-pitched wheezing, more of a snoring noise that you have. Okay, so again, these are your adventitious breath sounds, bad breath sounds. Know which ones are for which, like crackles are for pneumonia or pulmonary edema due to congestive heart failure. Wheezing is for asthma. Inspiratory stridor, think upper airway obstruction, so something is blocking the trachea usually. Stridor, again, think about it that way, the inspiratory stridor, right? And then the pleural rub is when you have the two layers of the lungs, that two outer layers of the lungs sort of rubbing against each other. And that could be, again, because of the fact that you have maybe inflammation within those layers. And then wheezing is for asthma. All right. And then if you're wondering what are normal breath sounds called, normal breathing sounds are known as vesicular or bronchovesicular. So if you're listening to lung sounds, remember, you should be hearing what they call vesicular normal sounds of air sort of going in and out. And remember, when you're checking or auscultating with your stethoscope for breath sounds, remember, you go from one side to another. So if I'm doing the top part of my right chest, I'm then going to move my stethoscope to the top part of my left chest. And then you're always doing a comparison, right versus left, okay? And remember, if you're hearing no breath sounds in a certain part of the chest, no breath sounds at all, that is concerning, okay? That usually means that part of the chest, either maybe the alveoli are collapsed there, okay? Or that the fact that you are not getting your ear into that absent breath sounds. If you're hearing absent, no breath sounds, pretty serious. That means no air is going in or out. You should never be hearing absent breath sounds. That means your airway has probably shut down. And that could be something that you can maybe experience in the very late stages of asthma, if asthma becomes untreated. You can have the absent breath sounds. Okay. Right. And then over time, if patients tend to have what they call chronic hypoxemia, chronic means that over time, this patient just has a lower oxygen level. They're not getting in as much oxygen, and the body starts getting a little used to that, right? Is it good or bad? Not really good, but the body does start getting used to that. And so you'll see that a lot in your patients that have emphysema, sometimes in chronic bronchitis as well, but primarily your COPD patients, you will see this. And chronic hypoxemia often is where they just normally have a normal amount of oxygen in the blood. And this is also the reason why we tell our, kind of educate our nurses on why we don't want to give them too much oxygen. It's also because their bodies over time become used to having a lower amount of oxygen in the blood. And again, it's not like it's like super low. They do need an adequate amount to be able to breathe, right, and to live. But usually in the COPD patients, about 88% to 92% SpO2 is completely normal, okay? Just because you see 88%, you're not going to automatically say, oh my God, they're at 88, what do I do, right? That might be normal for them. That might be baseline for them. Unless they're not having like extreme shortness of breath, 88% of oxygen are in the bloodstream. SpO2, which is the where you check with the pulse ox, is normal for COPD patients. Remember, chronic hypoxemics tend to develop what they call these sort of clubbing of the fingers. Okay, clubbed fingers. Clubbing of the fingers sort of looks like this. Clubbing. Let me see if they have a picture. And it can be clubbing of fingers and toes, but primarily it's going to be, oh, I just saw a picture there. Oh, here. This one too. This is finger clubbing, right? You can see normal and then on the right, clubbed fingers. So this is what it looks like when they have chronically low oxygen. Their body starts again. There's some changes that happen within other parts of your body because of this lack of constant normal oxygen. Clubbing of the fingers. That's what you'll be looking at. All right. I'm going to talk about acute respiratory failure. And so we can absolutely kind of try to finish up everything respiratory related today. So acute respiratory failure. And so when you're talking about acute respiratory failure, remember I did explain this COVID situation. And most patients that are acute respiratory failure do have to be intubated and ventilated. And so they're on intubation and they're on a mechanical ventilator. When they're getting acute respiratory failure, they basically go through 3 stages. Okay, the first stage is what they call the exudative stage. Okay, exudative means that they are having a lot of inflammation. They're having a lot of sort of, again, chronic inflammation, not chronic, but acute inflammation happening there, right? And so when this happens, your patients in acute respiratory failure, this is where you start to possibly see things like the cough and worsening conditions, right? But on top of that, the other manifestations, the other signs and symptoms that you see are oftentimes they're very restless, okay? Because again, they're not getting any oxygen. They start to act more confused. They are more agitated sometimes, or sometimes they can be very drowsy, very lethargic, okay? And we could see cyanosis happening. So you could see that they tend to have this kind of bluish tinge. We could see dyspnea happening. Okay, difficulty breathing. And remember, when we do ABG, so we're definitely going to have to do arterial blood gases on these patients, we tend to see a decreased oxygen level and a pH, and pH level can be varied, right? pH level can be high or it can be low, but mostly we'll see low because you're probably starting to retain a lot of CO2. And so your blood is starting to become more acidic. So remember, acute respiratory failure, you're starting to become more acidotic because you're retaining a lot of the CO2. And so like it says here, you have increased CO2, low pH, and low oxygen levels. Okay? And your body does try to compensate initially by increasing the respiratory rate, but that's compensatory, okay? And again, you're not gonna be successful in increasing respiratory rate because your lungs are pretty damaged already. So that's not super successful when it comes to that, when it comes to the acute respiratory failure. Excuse me. So with acute respiratory failure, remember that you have the 3 different phases, exudative, and then they can go into what they call the sort of the phase where you're kind of trying to, how do I call it? You're trying to kind of, your body's trying to compensate, or it's trying to sort of help, right? And this is where you have what they call the healing stage, where there's inflammation, but your body's sort of trying to say, okay, there's inflammation, but let me try to fix everything in here. And then what happens is that if it's not able to, the inflammation does not subside or does not go away, it leads to then the 3rd stage, which is what we call fibrosis, which is a scarring stage. And when fibrosis happens, there's really no turning back. Once it's fibrosed, once that tissue is hardened, remember the alveoli is super hard. It won't work like your normal lung tissue anymore. So you're basically, I guess, in a way, scarred for life, okay? And these patients, again, are not going to be able to usually survive without a ventilator. They need a machine to be helping them breathe. Or if they cannot be kept on a ventilator, if the damage is too much, then they might have to basically let them expire, let them die, because there's no, otherwise they have to be kept on a ventilator for life. And some people choose to do that. Some people don't want to do that. Okay, because again, it's a late stage. We're thinking about fibrosis as a late stage when the lung tissue just hardens. Okay, remember we do see cyanosis, guys. Remember, is a late sign. So you do see as soon as you're seeing more cyanosis, okay, that's a late sign of lack of oxygenation. Okay, early signs would be things like tachypnea, shortness of breath, increased heart rate. Okay, late signs would be more bradypnea, cyanosis. Okay, severe signs of respiratory distress would be that you're using a lot of accessory muscles and you're seeing what they call intercostal retractions, which means your chest sort of is sinking in and then going out. So when you're breathing in, instead of your chest sort of going out when you normally breathe, it sort of sinks in. Those are retractions. Okay. So remember that could be what you would see in acute respiratory failure. And here's what you can do, right? If you acute respiratory, we want to try to see what's the cause of acute respiratory failure. So of course we talked about infection, but other causes could be maybe you overdosed. Remember, if a patient overdoses, what happens? If I take too much morphine, what's the major side effect of morphine? Any idea? What's the major side effect of morphine?
It's respiratory distress.
Respiratory depression. Okay, so not distress, respiratory depression, because your respiratory rate goes down.
Okay.
Remember, it goes from less than 12 to about 10, sometimes even 8. So if your respiratory system goes down like that, remember, you're not getting enough oxygen and you're not getting rid of CO2, right? So at this point, you have to give them an antidote. And what is the antidote for reversal of opioids? Is naloxone. Okay, naloxone, also known as Narcan. Okay, so you guys, if you're familiar with Narcan, Narcan is given, it's a nasal spray that's usually given, and it's given, and it will reverse the overdose. Okay, we have a lot of Narcan use in everybody, even nursing schools. Well, in the Chicago area, I don't know, depending where you're from, we do have students being trained on how to use it starting from nursing school, because there's, again, a lot more opioid people are overdosing a lot, opioid crisis, right? Also remember, if they're on benzos, if I take a benzodiazepine, can you give me names of any benzodiazepines? Any benzodiazepines? So your anti-anxiety medications, so think about lorazepam, clonazepam. Okay, remember those, lorazepam, clonazepam, those are benzos. Okay, those medications can also help or cause decreased respiratory rate. They can also cause respiratory sedation. So what's a reversal agent for that? That is flumazenil. And you guys need to remember this, okay, flumazenil. So for benzos, which have the ending of lorazepam, clonazepam, okay, you're going to use reversal agent flumazenil right here. Okay. So the reversal agent for opioids are naloxone. Reversal agent for benzodiazepines, which is your medications like lorazepam and clonazepam, are going to be flumazenil. All right. So since we're on that topic, I kind of want to do a little breakdown here because I know meds seem to be like challenging topic for a lot of people, right? Opioids. So you already told me morphine. What other medications are opioids? Anything that you can throw out there?
The pain medication, I would say oxycodone.
Oxycodone, very good. Okay.
Hydromorphone.
What was the other one? Hydrocodone?
Vicodin.
Vicodin, yep.
Morphine.
Hydrocodone. You don't want us to use the
Hydromorphone?
Yeah, hydrocodone for
Hydrocodone, yep. So things like Norco, which is like a hydrocodone acetaminophen mix. Okay, those are Norco. If you hear the word Norco, which is it's commonly for Norco. Okay. Oops. What about tramadol?
Yeah.
Tramadol is an opioid. Okay, tramadol is an opioid. We have fentanyl as an opioid. So if you guys have heard about fentanyl patches, remember fentanyl patches and how they have to be disposed. Remember, we put the sticky ends of the patch together and we put it into the sharps container or flush it down the toilet, either one. Okay, we don't leave it in the regular trash because a child could come around or somebody could come around, the dog could come around and get it, and they could die of opioid overdose. Okay, and remember, fentanyl patches are usually kept for 72 hours. So it's kept for 72 hours usually, and then it's removed and then a new patch is put on. Remember, with any patches in general, you rotate sites. Don't put it on an area where you have lotions or creams or a lot of hair on. If you have hair, you can make sure you shave that, and it's usually put on the scapula, so on your shoulders, on your chest. Usually that's where the fentanyl patch is kept. Okay, that's 72 hours that we're looking at.
Witness also. To this.
Uh-huh.
A witness.
Oh, you said weakness?
Witness. To.
Oh, to dispose of it?
She meant, yeah, 2 nurses to
to dispose of the fentanyl patch. Yes, when you're disposing of the fentanyl patch. Yep. And that's a good one to remember. Also remember, this is given as transdermal. So when you see patches are usually transdermal, so on the skin. And basically fentanyl, which one's stronger, the fentanyl or the morphine?
Fentanyl.
The fentanyl is much more stronger, right? Absolutely. I'm going to give you guys some other ones. Methadone, if you've heard about it, this is given for your patients that are opioid dependent. So this is usually given to treat opioid dependency, because the benefit of the methadone is that it doesn't give you the high that the other opioids do. It sort of is helping them to not give as much the high, but it will control a lot of the pain and the cravings. So methadone is given for opioid dependence, but it is also a type of opioid itself as well. So methadone is there's one that you can remember as well. So opioids for you guys to remember, right? Now let's talk about benzodiazepines. We mentioned the lorazepam, the clonazepam. What other benzodiazepines can I have? Is alprazolam a benzodiazepine? Yes.
Yes.
Diazepam as well. And benzodiazepines, other than being given for anxiety, what else are they given for? What else are benzodiazepines also given for? For seizures. Remember, when patients are having seizures, we usually give them IM diazepam or lorazepam. So IM Ativan. Lorazepam is Ativan, right? For seizures, we give them that. Okay. So not only for anxiety, but also for seizures. When they're having active seizures, we can give them benzodiazepines. Now, going back to your opioids, the biggest side effect that you have is the respiratory depression. Okay, what are some other things that you can have? You can have constipation when you're on this, like major constipation. So education point is increased FNF, fiber and fluids. They can also have urinary retention. So everything is sort of kind of slow in your body at this point when you're on opioids, right? Urinary retention can be something that they can have. We can see that they can have tachycardia, and they can also have hypotension. Okay, so that's what you see with opioids. Okay, now when you look at benzos can also put you into some sedation. So benzos can also make you drowsy, just like morphine or opioids can also make you kind of drowsy. So you want to be careful when you're handling machinery, things like that. Okay, so drowsiness. And also hypotension is something that you can have as well, but not as much as your opiates or anything like that. But definitely that sedation is a big major one that you're looking out for. So it's just a little side note there about opioids and benzodiazepines. Right? Okay. So when you are on acute respiratory failure, sort of going back to that, remember we give them oxygen therapy, we're getting them oxygen. We are giving them antibiotics, okay, if they need it, because maybe it's an infection of the lung, that like a pneumonia that's causing it, and then we get them antibiotics. We also give them bronchodilators for telling them to cough and deep breathe if they're able to, and then we're suctioning as needed, because remember they can have a lot of mucus down there, and then they're usually on mechanical ventilation, etc. Okay. And then respiratory failure, when it leads into that, what they call the 3 stages that I mentioned, they're known as ARDS, or acute respiratory distress syndrome. Remember, once they have ARDS, it's hard coming back from that. Okay, it's really kind of major damage that happens to your lungs that you have. Okay, and then remember, you can have atelectasis and fibrosis. So atelectasis is the collapse of the alveoli, and fibrosis is sort of the hardening of the tissue that you have. Okay, atelectasis, remember, is something that is very common, and also what kind of patients? Or do you have atelectasis in, which is collapse of the alveoli? What kind of patients do you think you're going to see that in? Your atelectasis. Any guesses? It's very common after surgery. Okay, why is that? Because after surgery, people are usually not doing deep breathing exercises, or because of pain, etc. They're not moving around as much. They're not taking those deep breathing exercises. So you're using the incentive spirometer. Remember the incentive spirometer? You've seen it a lot at patients' bedsides if you worked in the hospital or just anywhere really. But basically, the incentive spirometer is a machine that they breathe into. It's like this. Okay. And it's given to kind of open up the airways. So they breathe into this, and their goal is to kind of raise this up as high as they can, or up to the blue ball that you'll see on here. So that's the target area for your incentive spirometer use. And they're educated to do deep breathing and coughing. Now, if they don't, then they have the alveoli, the little alveoli, the little balls in your lungs are going to collapse. Right? If it collapses, then that's not a good thing, because then you're going to have difficulty getting air in and out. Very common in your post-operative patients. So your biggest risk factor is patients that have had surgery. You're really thinking, hey, this patient could go into atelectasis. Okay. We are also going to consider something called pneumothorax. If you guys have heard of pneumothorax, what is the cause of a pneumothorax? Any ideas? What is a cause? And it's right here, right there at the top. What is the cause of a pneumothorax?
Is that when air enters the lungs?
Yes, it is when air enters the lungs. Yep, exactly. But why does that happen?
It's when we have an opening, like let's say if the patient has like an invasive procedure, like IV or
Could be, but I'm also thinking just trauma.
trauma. Yes,
Just
trauma injury. Yes, injury, trauma injury.
Yep, exactly. So trauma and injury. Yes, very good. So any trauma, usually think about it, somebody who's gotten in a car accident. Remember the car accident, maybe the airbag inflates and it sort of causes what they call blunt injury. So basically the rib cage can actually a sort of puncture, right? The rib cage becomes broken and the rib cage punctures the lungs. So like you said, anything where you accidentally nick like that space where the air is, like you accidentally cause air to go into that area. And mostly it is traumatic. That's where you can see that collapse of the lung sort of happening. And so when this happens, basically the lung collapses in whichever area the injury was in. And when they say lung collapse, what they're basically saying is that air enters the space. It's not that your actual lung is like broken or anything like that. It's just that air comes in here. So when air comes into this cavity where it's not supposed to be air, it puts pressure on that lung. And so the lung actually just moves into a corner because this air is sort of putting pressure on it. So it's not able to expand anymore with air. Okay. So what happens is that we have to take this air out. So we can do one of two things. They can do a procedure called a not this one. They can do a procedure called a thoracentesis, where basically they will go ahead and they will and we'll talk about this. This is a chest tube, but in a thoracentesis, they will go ahead and they will use a needle and they will pull out whatever is in there. So it could be fluid, it could be blood, it could be air, but they're going to do whatever it is and they're going to do a thoracentesis. And usually when they're doing a thoracentesis, the patient is leaning forward like this, okay, on a tripod positioning, and they're going to insert a needle and they're going to pull whatever it is. Sometimes it's blood, sometimes it's fluid, sometimes it's just air. They're going to pull it out. Once they pull it out, the lungs are then able to re-expand into the space. That's thoracentesis. But what if they still have producing a lot of drainage and they just need more things to help clear that out? Then they will be placed on what we call a chest tube. Okay, if you guys are familiar with chest tubes, and again, this might be more for your RNs that you need to know, because you won't really see this other than in the hospital, really. But chest tube basically is going to be attached to the patient's what they call pleural cavity. Right? It's attached to the pleural cavity, which is the space that we're talking about, right? The space where the lungs are sitting. And the goal of the chest tube is to be able to pull out whatever drainage, whatever is in their blood. And it looks like this. Okay. And this is a chest tube. Okay. The chest tube basically has 3 chambers. Okay. It's got what they call a suction chamber. Okay, this is right here, water-filled suction chamber. You've got the collection chamber, which is where all the drainage and the fluid is going to be getting collected. And then you have the water seal chamber, which is the red one in the middle. Okay, now there's a couple of different things that you need to know about chest tubes and what's normal and what's not. Anyone want to mention anything that is not normal with a chest tube?
Why is that when there's no bubble?
Yeah, so the bubbling is one of the issues, right? So if you're seeing constant bubbling, okay, that is not good. Okay, constant heavy bubbling is not good. What is normal to see is something called titling. Titling is when you have sort of when you're taking in, inhaling and exhaling, you should see the water rise a little bit in the water seal chamber.
Kind of like a
That's okay.
friction.
But if you're seeing continuous bubbling, that tells me that there's some sort of air leak, and that is not good. Okay, so slow rise with breathing of the water is okay, but continuous bubbling indicates to me that there is some issue. Okay, there is something going on. There's some sort of leak. Okay, that's in the water seal chamber. So remember, where is the continuous bubbling? In the continuous bubbling in the water seal chamber is concerning. So the area in the middle, the right here. But if you're having a bubbling within the suction chamber, that is okay. Okay, remember that. Within the suction control chamber is okay. Continuous bubbling in there is okay. That's actually what you want to see, but not in the water seal chamber. Okay, so just differentiate between that, right? Remember, what happens if the chest tube comes out? Okay, what do you do? What if it comes out of your chest? What do you do?
It's like you put a dressing dressing
Mhm.
to cover it,
Yep.
and I don't know. I forgot about those things.
I
I haven't
think
studied it
I
in a
think you
while.
give oxygen.
Absolutely, you give oxygen, sure, but there's a specific way that you do the dressing. Remember, you only secure 3 sides of the dressing.
Yes, you secure
Yeah.
it.
Yep, only secure
And I
the 3
think
sides.
okay, yes, you
Okay, and this is going to prevent air from going in, because if air goes in, what is it going to cause? It's going to cause a
trouble.
pneumothorax. Yes, it's going to worsen. It's going to cause a pneumothorax, right? So usually place a sterile dressing over the open hole, and then you cover it with another regular gauze pad, and then you tape only 3 sides. So you leave one side open to let air out. Okay, that's one of the things. Now, what if the chest tube comes out of the actual chamber? So do you see, what if it comes out? What if it's within your chest, but it comes out of this part right here? If it comes out of this part or something happens here, then you have to put the tubing into a sterile container of water.
Okay, this is exactly what I was trying to figure, because I remember something like
Yep. So you'll put into a sterile if it becomes disconnected from the drainage system. So if it becomes dislodged from your chest, you do the sterile gauze on the 3 sides. If it just becomes disconnected from the drainage system, that's when you would do you would put the tubing into a sterile container of water. Okay, and that's basically to create a water seal, so the system is damaged until you're able to sort of reconnect or replace the system. That's something that you do. And again, that's something where maybe the chest tube itself is malfunctioning. That is something that you would consider as well. Yeah, this is what the chest tube looks like. Remember, chest tube needs to be below the chest. Don't put it over the chest, just like when you're talking about your Foley, same concept. It needs to be below the chest, because then you don't want the drainage going backward. You want everything sort of coming out, right? Okay, you are for chest tube and complications. When you have a chest tube, you're watching out for what they call crepitations, right? And once they insert the chest tube, what can happen is that crackles happening under the skin. That's crepitations, and that's called a subcutaneous emphysema, which means air gets trapped under the skin. That is a common complication of a chest tube. Okay, the other common complication is what they call tracheal deviation, and that's what the pneumothorax as well. That's also called a tension pneumothorax, and this is a big one to remember. Tension pneumothorax is when that trachea is going to deviate away from the bad lung, and it's going to go towards the good lung. And this is pretty serious, guys. If you can see this picture right here, you see this trachea, it's getting away from the bad lung, the pneumothorax lung, towards the good lung. And the problem with that is that if the trachea deviates, you're not able to get air in and out adequately because the trachea is deviated to one side. And this is a major medical emergency. They usually have to get an immediate emergency thoracentesis to pull air or whatever is in this collapsed lung, whatever is in this pneumothorax, they have to pull it out. Okay, immediate things that they have to do for attention pneumothorax. Yeah. And that can also happen as a complication of having a chest tube as well. They can have the tracheal deviation, etc. Okay. Okay, the next one I want to mention, guys, is a procedure. You always get questions on this procedure called a bronchoscopy. Remember, bronchoscopies, should the patient be NPO prior to a bronchoscopy?
I can say yes.
Yes, they need to be NPO because remember, they're going to stick this tube down your throat, just like when they do an ET tube insertion, but this is what it looks like. Okay, they're going to put it down your throat, and of course they have a camera. It's called the scopy, so then the doctor can see as they move the scope down what is happening within your lungs. This is usually done for patients that maybe they suspect there's some cancer going on, or maybe they're not able to identify what's the actual cause of this lung problem. They usually will do a bronchoscopy, and they will put this down the throat. So they're usually told to be NPO. And the fact that after the procedure, what are you watching out for?
Gag reflex.
You are seeing respiratory status first, gag
Exactly.
reflex, and you monitor vital signs. You assess your breath sound.
Yep. Gag reflex. You're waiting for that gag reflex to come back because remember, they had just had anesthesia, so you don't want to give them any food or anything to drink before you want to make sure the gag reflex comes back before you give them anything to eat or drink. Okay, so they're NPO until the gag reflex returns. Remember, they can use an ice collar for throat discomfort. A tiny spotting of blood is okay. A little spotting of blood is okay. Heavy bleeding is not okay. Okay? And we do want to watch out for things like subcutaneous emphysema as well, which is, remember, the air getting trapped under the skin with something like this, and dyspnea as well. Okay. Thoracentesis we talked about. Remember, in thoracentesis, which is where they pull the fluid out from the lungs, the patient has to be in a high Fowler's position or sitting on the edge of the bed with the feet supported on the chair. And this is to facilitate accumulation of fluid in the base of the chest. So this allows for fluid to sort of just get all that fluid to the bottom of your chest, right? Just by gravity. So I always call it the sitting up position, the tripod positioning, or they're in a high Fowler's position for thoracentesis. Okay, well, just like here. We talked about the medications already. Okay. You don't need to know so much about that. I'm going to give you guys some more medications, and don't get too confused. I just want to have you guys somewhat be familiar with this. So another medication I want to give you is this medication called Montelukast or Singulair. I'm sure you guys have heard enough commercials about Singulair, right? And basically this medication is given to your patients that have asthma. It prevents the wheezing because it reduces the constant inflammation that asthma patients have. A lot of asthma patients tend to have a lot of inflammation, and so this drug Singulair will reduce that. Okay, it's called Montelukast or Singulair. So it kind of suppresses the immune system a little bit as a drug, and it's going to sort of reduce inflammation that way. Okay. Again, indications is chronic asthma and things like that. Okay. The corticosteroids we already mentioned: dexamethasone, fluticasone, beclomethasone, all that. I want to go back and mention. Okay, there's these medications also called mast cell stabilizers. Again, it sort of works, again, same way as your Singulair. It sort of stops certain cells within your immune system from functioning, so then it decreases the inflammation. So the big one that you need to remember is what they call cromolyn or cromolyn sodium. And remember, why are we giving them to these asthma patients? Because in asthma, you have a lot of inflammation. You have a lot of this chronic inflammation going on. Okay, so like it says, it prevents the release of histamine. Remember histamines, if you guys have heard of histamines or antihistamines, like Benadryl is an antihistamine. Histamines are things in your body that cause a lot of irritation and inflammation, right? Your immune system releases them to alert your body that there is some sort of inflammation or some sort of issue going on in that area. And so histamines are going to be the ones that sort of cause that irritation and that runny nose and that mucus and that inflammation. So basically this medication is going to stop the release of those histamines and then prevent inflammation that way. Okay. All right, ladies, I'm going to have you guys take a good look at a respiratory case study that I have here. And then we'll do a little bit more of topics, and I think we should be able to wrap up respiratory, like the big major ones anyways. Okay? All right, so you've got a nurse in the ED caring for a 57-year-old male client. Okay, 57-year-old male client comes to the emergency department after feeling short of breath and having a cough for the past 2 days. The client reports sleeping on 2 pillows and waking up coughing several times a night. Expresses feeling very fatigued lately and spending most of the day in bed or chair. Client appears anxious. He has a history of hypertension, hyperlipidemia, chronic stable angina, and diabetes mellitus type 2. Client expresses concern of inability to afford current medications. Okay. We have assessment findings here. So taken in 1030, he's oriented times 3. Okay. He's got crackles throughout all his lung fields. S1, S2, and S3 are present. Bowel sounds normal active times 4. Capillary refill less than 3 seconds. Pulses 2+ all extremities. +1 pitting edema bilateral lower extremities. Okay. So if you're having S1, S2, and S3 present, remember S1 and S2 are normal heart sounds. You want them present. That's the lub-dub, That's normal. S3 is normal in some situations. Normal meaning it's an expected finding in some situations. For example, if I have a lot of edema, or if I have a lot of pulmonary edema, or if I just have fluid overload, there's just more fluid circulating around in my lungs or in my body, I can have an S3 heart sound. And S3 heart sounds usually are going to be because of, again, you have extra fluid. And so think about a woman that's pregnant. Sometimes it's normal to have an S3 heart sound. It will go away once the pregnancy terminates, once the pregnancy is over. Okay. So any situation when you have fluid overload, you can have S3. So S3 is normal in some cases, but not completely normal, but it can be normal in some cases, right? S4 heart sound is completely abnormal. If you're hearing S4, that means you have a specific true heart murmur going on somewhere, and you need to, again, get immediately seen and see what's going on. Okay. When it says bowel sounds normal active, meaning that you can hear bowel sounds at all quadrants. Okay. Remember, when you're checking for bowel sounds, you always auscultate first, right? Inspect, auscultate, and then you'll do palpation last, because you don't want to move anything around when you're checking your abdominal assessment. So you always do inspection and then auscultation, so listening with your stethoscope, because you don't want to mess up the abdominal sounds. And then you will do percussion, which is a little tapping. Okay. And when you're percussing the lungs, percussing is that little tapping assessment that you do, you should be hearing a sound called tympany. Okay. That's normal. If you're not hearing tympany, that's not normal. Okay. And then the last one is where you'll do palpation. You always want to start with light palpation. You don't want to jam your hands into somebody's stomach and then go into deep palpations to get more comfortable. Okay. The most painful areas you will keep last. Okay. And that goes for any assessment, basically. Okay. And then remember, capillary refill should be less than 3 seconds. That's normal. What is a normal capillary refill? It should be less than 2 to 3 seconds. Remember, capillary refill tells you how well your extremities are oxygenated, how well your blood circulation is. Pulses 2+ in all extremities. Is that normal? You have 2+ pulses in all extremities.
Yes.
Yes, normal. Okay. And what about the +1 pitting edema?
No.
No.
It's not normal at all. Okay, perfect. Okay, let's go down to vital signs. Here's vitals for you guys.
Pulse is abnormal.
Mm-hmm.
Respiratory rate is abnormal.
Correct.
What was the patient? Let me see. Go back. After shortness of breath. I'm trying to see if the pulse oximeter. The patient, I don't remember if the patient. Incorrect too? Okay. Let me see. 89 should be. No, it's no good for this patient. Oh, chronic COPD. Let's see, chronic. Oh, chronic stable angina. I thought it was COPD. I think it's incorrect too.
Okay. All right. So we have that much assessment information. Okay. Oops. Let me just stop sharing for a second. I just didn't realize that the answer is on there already. Okay, let me reshare. Okay. There we go. Select the top 4 findings that require immediate follow-up on here. I can go back to the case study and if you guys need me to. Or actually, you know what? Let me just see if I can just copy a smaller version of it down here. There. Okay. So 4 findings that require immediate follow-up.
Immediate follow-up. Oh, immediate follow-up. But
Mhm.
okay, I have a question. When they say immediate on a question like this,
Yes.
I see immediate follow-up,
Mhm.
and we have to select all the answer, all the option that we need to intervene right away. But like for the respiratory, for the number 4,
Mhm.
respiration, it's abnormal. If
Correct.
it's no, this one is abnormal. We should pick that.
Yes, because if you correct,
Pulse
if you go back on
oximetry.
here,
So
respiratory is
yes.
25. That's pretty high.
Okay, what I meant by that, all the abnormals, do we pick them up on a, because some questions it might not required to pick up all the abnormals, but immediate
Yes.
intervention.
Immediate, and you also have to prioritize. So this is where you have to, so this is the type of question where here's my
Yeah,
hint
we
to you,
need to
right?
analyze the question more because
Yep.
this is where I get confused sometimes.
So
Even though the question is easy, but the way you interpret the question, it makes you
correct.
lose the question.
Correct. So in this, guys, in this problem, when you look at it, what's the major concern? Is it airway, breathing, or circulation? What's the major concern here?
I think it's airway at this time because it's all about.
I would say
It's
airway and
mixed, but I will
breathing.
go breathing. Airways that's still breathing.
I would say airway and breathing. Okay, because when you're talking about
Yeah,
airway,
airway
airways,
and breathing. When I say airway, oh yeah, we have to prioritize.
right. So
Okay,
if I'm
airway.
thinking airway and breathing is a major concern, then I'm going to pick things that require immediate follow-up related to airway and breathing.
Yeah, which is
Which is
breathing,
Shortness of breath.
it's
7.
respiration,
yes,
crackles, and SOB number 7, number 3, number 4, and the pulse oximetry is abnormal.
Yep.
Inability to afford. No, not this one. History, not that one.
Okay,
The
and
blood
here's
pressure,
my
I can say. What
hint.
about the cough?
So is the
Edema?
cough, look at the cough, and it says the cough has been for the past 2 days. Is the cough something immediately? If I don't deal with the cough, are they going to immediately possibly?
No, the cough been there for 2 days.
Correct. It's been there for 2 days. So you guys, you have to
It's not an
differentiate.
urgent matter.
So you have to also look at, is it urgent? And number 2 is, if it's been there for 3 or 4 days, they're not going to immediately die from
No,
it.
it's not. No, it's no longer urgent because we
It's
have
not
other
acute.
priorities. Because
Correct.
if it's there for 2-3 days and they did not do anything, it's not a major thing.
Correct. Also, anything related to history, if it says history of something, that is not an immediate follow-up. Because
Yeah,
it's a history.
yeah, I realize that because he or she's been having the chronic stable angina. Inability to afford medical is not part of it.
Yeah, and again, it's
Edema,
not
they say
immediate.
one pitting edema.
So it says 1 plus of pitting edema, and pitting edema is usually on your extremities, right? On the bilateral lower extremities.
Yeah,
Is that
but
immediate?
but we all know once you see it, it's no good.
Yes, we do see it. We know it's a bad thing to have, but does it
But
require immediate follow-up?
not
No.
at this time.
Right.
It is not
It's
something
airway,
to
breathing that
intervene
you're
right away.
prioritizing. Yeah.
Then okay, we're good.
Okay. Yeah. So also want to add something on here is that you need to know, that's the reason why I'm covering a lot of pathophysiology for you guys, because sometimes you need to know what is expected. What is expected versus what is not expected. Meaning some conditions, for example, if I'm, I don't know, if I'm having COPD, right? It's expected that I'm going to have an oxygen saturation of 88%, right? That's an expected finding. Would that require immediate follow-up?
Oh no.
No. Okay, so you also have to, when you look at this question, you also have to know what is expected for a disease condition. So that's where your knowledge of these diseases come up. Okay, if it's expected 88% and expected 88% is okay for a COPD patient, you don't intervene. Okay, you would not have picked up the pulse ox if the patient had 80% and they had no other symptoms. You would not have chosen pulse ox because
Yeah,
that would
but
be
also in a different situation, if the pulse ox is 89, we have to intervene. It is something that we
correct.
have to intervene right away.
Intervene for, correct.
Okay.
Yes. Okay. So that's how you would sort of approach these questions. And these are tricky, but again, your goal is to get as much as possible. And sometimes you won't get 100%, sometimes you will, but your goal is to get as much as possible. Okay. So it says the nurse recognizes the crackles throughout the lung fields, throughout the lungs in this client are due to what? So why is this patient having crackles? And this is the second part of the question too. Are due to pneumonia, heart failure, or reduced mobility. I can go back here if you need me to as well.
That's a fluid accumulation.
Okay, so I've got a fluid accumulation, okay. And then for what about for this one?
But if there is fluid accumulation, it could be related to heart failure
Or pneumonia.
or but pneumonia. I was gonna.
So how do we determine if it's pneumonia or fluid accumulation? So let's look back at some of their
Collapse.
So what tells you on here that this is pneumonia versus fluid accumulation?
In which part? Okay.
Any of these, yeah.
What was the question again?
So what can tell you if this patient is having pneumonia versus fluid accumulation, or pneumonia versus heart failure? What can differentiate between that? We talked about heart failure already, and we didn't mention pneumonia that much, but we talked about heart failure. So what can tell me this patient is not having heart failure, but maybe they're having pneumonia or vice versa?
I'll tell you pneumonia.
One of the patient has edema. This is fluid retention.
Okay, they're fluid, but they could have. So you're telling me that they have a fluid accumulation, okay? And you're telling me, but which one do you think? Pneumonia, heart failure, reduced mobility. So this is where
who's laughing?
Yeah, this is where you need to know why different processes. So in heart failure, remember, what are some symptoms of heart failure that we talked about? We talked about that they have fluid buildup.
I think it could be because the reason why I think the pneumonia is is when you have pneumonia, you might have fluid accumulation, but at the same time, it's a lung infection. But for the heart failure,
what
this
tells
is
me
No fever.
on
No
here?
fever there.
Yes, no fever. Okay, this is 98.9 is still considered to be within normal. There's not much.
No, it's not another patient doesn't have fever.
Yeah, this is why it would not be pneumonia, because pneumonia.
But at the same time, patient with heart failure can develop pneumonia.
Yes, they can, but we're here. They're different. They're just asking to differentiate between heart failure and pneumonia. And heart failure patients can develop pneumonia. They're more likely to get pneumonia, but there's not a direct correlation. Just because you have heart failure doesn't mean you're automatically going to get pneumonia. You're more at risk.
Repeat heart failure.
Yeah, could get it.
Yeah. And do you see reduced mobility? I don't see reduced mobility in this patient, because reduced mobility, I'm usually thinking most of your surgical patients. Okay, I don't see any reduced mobility in here. So this automatically makes me think that they are probably having CHF. What else on here can tell me that they're having CHF? What about the respiratory? Crackle.
Because shortness of breath.
Yep, and the crackling.
And edema, crackle.
Yep, and the pitting edema, very good. And then they have an S3 sound. Remember, S3 is usually due to fluid overload.
S3?
Remember, S3 heart sounds is usually due to fluid overload. So they are having crackles, which is a big sign. I'm thinking a lot of fluid in the lungs. S3 means that they have a lot of fluid in the body, fluid overload. And this is telling me pulses are 2+, which is okay, but they have pitting edema, which means that they're holding on to a lot of fluid. All key signs, you see how many? 1, 2, 3 signs, all saying that I have fluid overload. No temp, heart rate is high, okay, and blood pressure is high too, which means that I'm retaining a lot of fluid within the system, okay, and my heart is working extra hard to sort of pump it out. So yes, I'm going to have fluid accumulation, and I'm going to be having heart failure. Does that make sense?
Yes.
Anytime you guys get anything related to infection, look at the temperature. If say you get something like sepsis or pneumonia and you see the temperature is normal, you can automatically rule that out, because those things that you're going to have elevated temperature. Okay. Anytime you get heart failure, think crackles, think S3, heart sound, think that there's going to be pitting edema, think that there's going to be maybe hepatomegaly, splenomegaly, the enlargement. Maybe they're going to be complaining of some pain in that area. Okay. Think the fact that they're going to have edema all over their body. All right. When you have pneumonia, remember, you're going to have not only the high temperature, you're probably going to have a productive cough, a cough with sputum. Okay, you're going to see that they are going to have maybe sometimes even a dry cough, but they're definitely going to have an elevation in temperature. All right. Okay, so here's the question. The client is at highest risk for developing blank and blank. So we have options of respiratory failure, acute kidney injury, sepsis, or pulmonary embolism. What do we think? So highest risk for developing what? So what's the most common one that we can pick on your highest risk? So you already told me that they have heart failure. So what can they, if the heart failure doesn't get treated, what can their lungs do?
Pulmonary
What are we
embolism.
talking about right now?
I think it's not sepsis, it's not respiratory.
It's not sepsis because the temperature would have been elevated, right? Yep, so we can rule that out. Okay. What's pulmonary embolism?
It's when air enters the lung.
Nope, that's pneumothorax.
Oh, that's pneumothorax, blood clot.
So yeah, you can have a blood clot sort of in your pulmonary artery. Remember, the pulmonary artery is the artery going from your right ventricle to your lungs. You can have embolism stuck in there, meaning that you're not going to be able to get blood into the lungs, so no oxygen. Okay, do you think they have any risk for pulmonary embolism? So let me go back here. Does it look like they have?
Yeah, I was gonna say, do we have any change in change of condition? No.
Nope, no change of condition. So all the
Same thing.
Yep. So does it look like they have?
Like
They only have +1 pedema, but that's in both extremities. If they had a DVT, okay, they would be at risk. Does it look like?
Yeah, okay.
No.
There's no such thing.
DVT would be what? You would have maybe redness in one leg. It's unilateral, right? And maybe you could have cold feet, redness to the calf, pain, nothing. Okay. You just have +1 pitting edema in bilateral lower extremity, so I can rule out the fact that they might have a DVT, which can then break off and then become a pulmonary embolism. And pulmonary embolism, guys, it's quick. So what are you going to see? Are you going to have a shortness of breath and feeling short of breath? For
yes.
No. If I'm feeling short of breath,
pulmonary embolism, you're not going to have shortness of breath?
You're going to have shortness of breath, but it's acute. It's going to be immediate.
Oh, okay.
For this patient, it says short of breath for 2 days. You're not going to be short of breath for 2 days if pulmonary embolism. You'll die. Okay. You will have acute shortness of breath, meaning and then chest tightness and chest pain right away. Pulmonary embolism. You're not going to be alive for 2 days. Okay, so we can automatically take that out. Okay, that leaves us basically with respiratory failure, which we know. Remember, if all that fluid and that inflammation within the lungs, if I don't take care of it, it's going to lead my lungs to be getting damaged, right? All that fluid is going to lead to a lot of damage to the lungs, all that crackles. Okay, so respiratory failure, and then acute kidney injury. Why do you think I could be an acute kidney injury? Why?
Because of the respiratory failure. Because if the heart when the heart has a condition, it affects the kidney. But I don't. I really know the reason why, but I need to come up with the words.
Okay, so the acute.
I would say too much fluid.
Yes, very good.
Hypokalemia.
Yes, very good. Too much fluid. Okay, that's the primary problem. You have so much fluid in your body that your kidneys are going to be sort of overworked. Okay, and then that's why acute kidney injury is a biggest issue, is a complication for congestive heart failure patients, because of the fact that it's also putting stress on your kidneys because of the extra fluid that your kidneys have to work hard. All right. Okay, very good. So that covers that part. Oops. Let me just stop sharing for a sec. I'm going to take this one out as well. And then the next one, it's where they ask you, and they're really asking you to think like a doctor. They're saying, hey, what do you think this nurse is going to anticipate? Anticipate meaning, what do you think this patient is going to need based on what you're seeing? Okay, so here's your question. Okay. So it says, select whether each intervention is anticipated or not anticipated in the care of this client. Are you going to obtain blood for culture? Anticipated or not anticipated?
Yes.
Why am I collecting blood for culture? Culture is only done if I suspect infection. Do I suspect infection here?
No.
Ew, no
No.
test.
Check for kidney. I don't know.
No, obtain blood culture.
No
Culture,
signs of
no.
infection. No, so no culture. Culture, remember, is we see is to check for bacterial growth. Usually a urinary culture is done, blood culture is done to see if it's spread into the blood, but no. If it's spread into the blood, that means it's going towards sepsis. If I see that the blood is infected with bacteria, I'm thinking bacteremia, which is bacteria in the blood, and then I'm thinking sepsis because there's there's bacteria in the blood. Okay, obtain sputum for culture.
No.
Ew.
Mm-mm.
Prepare
No,
for
it's for lungs.
echocardiogram.
Yes.
Yes. And what are we going to find from the echocardiogram? What are we looking for? The ejection fraction. Remember,
Oh,
ejection
okay.
fraction is checked in your heart failure patients because it tells me how much blood, the percentage of blood being pumped out. If it's less than 40%, is that good or bad? If it's less than 40%, it's bad.
I'm sorry.
Okay.
Can you repeat that again?
Yep, the
Echocardio.
ejection fraction is the amount of fluid that's being pumped out by the heart. And remember, this patient is in heart failure. So if they're in heart failure, if I have an ejection fraction of less than 40%, is that good or not?
You just say bad.
It's bad. Less than 40% tells me that they're in heart failure. Okay, normal ejection fraction is about 55 to 75% in you and me, normal adults. Okay, if they have ejection fraction less than 40%, it means that they are going to be in heart failure, and that is not good. So an echo, remember, is the ultrasound of the heart, not an EKG. Remember, EKG is electrocardiogram. This is echocardiogram. Okay, draw serum renal function tests. Yes or no?
Yes.
Yes. And what are renal function tests? Give me the names.
Yeah, because we need that.
What are the names of some renal function tests?
B1, yeah. B1.
Yep. What else?
And the creatinine.
Creatinine. Yep. What else? So you've got B1, you've got creatinine, you've got GFR. GFR levels, glomerular filtration rate. Remember, the lower the GFR, the worse the kidneys are. Yep. All right. What about administer supplemental oxygen?
No.
Why not? They're on 89% on room air.
89, yes, low.
Oh, okay.
No COPD, guys, so this is okay. You can give them oxygen. Don't be scared. Okay, this is not a COPD patient. You can give them an administer supplemental oxygen. It's just going to help them breathe. Because you can see on here, because you're breathing so hard, what else is high? Their respiratory rate is high and their pulse is also high. So yes, you can give them oxygen. Okay, no COPD, no problem. Okay, obtain 12-lead electrocardiogram. Do I need to do a 12-lead electrocardiogram for this patient? What do you think? Look at something on here. What tells you on here that they need to have an electrocardiogram?
I don't think I know.
The chronic, even though they have the chronic stable angina, we don't know that they could be, heart failure patients can go into arrhythmias. They can go into different arrhythmias. So they do need to get an EKG. So I would say anticipated. Okay. What about draw serum B-type natriuretic peptide? This is also known as BNP. Okay. Do we need BNP? BNP will tell you how bad your heart failure is doing. If my heart failure is really bad, my BNP is increased. All right. And do I need to take that? Do I need to do the BNP level?
Yes.
Yes, because we suspect this patient has anticipated. And guys, remember, this is different from BMP. BMP is basic metabolic panel. Oops. Okay, basic metabolic panel, BMP. Okay, that's just your blood work. Okay, that's like your sodium, your potassium, that's all BMP. This is BNP, B-type natriuretic peptide, and it's a specific blood test that is done for heart failure patients to see how the heart failure is doing. Okay, all right, any questions on this one? No, okay. All right, here is, so now you get laboratory results for this patient. So they have lab results coming in here at 11 o'clock. When you get lab results, the norms are on the bottom. This is the normal values. And on this right is what the patient's results are. So what on here is abnormal?
The sodium.
The sodium and?
Let me put it up. Potassium.
The potassium, is it normal?
It's normal. It's normal.
The BNP, the B-type natriuretic peptide, it's supposed to be less than 100. What is this patient's? 600. So does this mean that they're in heart failure? If you look at the BNP, it doesn't mean that they're in heart failure. It should be less than 100, if normally. So they're 600. Does that mean that they're in heart failure? Yes, this patient is in heart failure because it should be less than 100, but their BNP is high, so they're in heart failure. Sodium, why is sodium so low for this patient? What could be a reason? You're retaining too much of what? Fluid, so it's diluting the salt. Yes, okay. All right, and this is this last question on here. The nurses reviewed the laboratory results from 11 o'clock. The healthcare provider diagnosis declined with heart failure. Which of the following order should the nurse prioritize? What do we think? Which one are we going to prioritize here?
The third one? The patient
Third
is
one.
going to be on Lasix.
Yep, the furosemide, which is the Lasix, and to get rid of the excessive fluid. What about B, enalapril? What drug is that?
That's the blood pressure. Yeah.
Yes, antihypertensive. It's an ACE inhibitor, and remember, ACE inhibitor side effects are high potassium, do not give to pregnant women, etc. All right, so that wraps up this part. I'm gonna brush up, see what else we need to cover on respiratory really quickly here. Tracheostomy here, that's what we need to cover. Yeah, that's a big one, tracheostomy. Guys, remember tracheostomies have several different components to it. We have the stoma, right, which is where the tracheostomy tube is inserted. And then you have a couple of different things. You have an outer cannula and then an inner cannula and what they call the obturator. So I'm going to show you tracheostomy components here really quickly. Okay, tracheostomy components. Okay, tracheostomy, you have, this is the outer cannula, and this is the inner cannula. The inner cannula goes in here. Okay, and then you have an obturator. An obturator is used if this outer cannula comes out, you can put the obturator in there to help you guide the outer cannula back in. Okay, the inner cannula is what we can remove. So when we're doing suctioning or when we're cleaning, we can remove this inner cannula from this part. We can remove it and we can clean it. We can put a new one in. Those are the things that we can do because a lot of secretions get stuck in here, right? All right, what we have also is this pilot balloon is what they call it. And this is going to be on the outside of this patient. And this pilot balloon, if it's nice and inflated, it tells me that this cuff here, which is inside the patient, is nice and inflated. If it's loose, it tells me that the cuff here is loose. Maybe there's some leakage going on. But if this cuff is not nice and tight, this trachea is more likely to come out. So I don't want that to come out, okay? And then the part that goes against your neck is known as the faceplate. right? So I'm going to show you a picture of tracheostomy in a real patient. Okay, this is what it looks like. Okay. So you can see that they have this tracheostomy here. They have this little pilot balloon, as you can see on here. This is stuck out. And what you see sticking out here is probably the inner cannula. And the outer cannula is obviously inside of the patient. The inner cannula is inside. So the inner cannula is the one that you can take out. Okay. When you're doing tracheostomy suctioning, remember we suction. Do we suction when we go into the patient, or do we suction when we come out of the patient?
When you come out.
When we come out.
When you come out. And how many seconds of suctioning can I do? 10 to 15 seconds at one go. Okay. And no more than 3 passes, meaning at one time, I should not be suctioning more than 3. Okay. And remember, I need to hyperoxygenate the patient with an ambu bag. Okay. Hyperoxygenate means that you're going to give them more oxygen before I start. Yes, before I start suctioning them. Okay. And they're going to use this ambu bag right here. They can attach it directly to the tracheostomy, and they can give you attach it to oxygen and give you like bumped up oxygen. What do I need to do before I take vital sign, or before I suction? I need to get a set of respiratory rate and oxygen saturation before I start suctioning, because that will tell me if the patient's oxygenation improved. Okay. When I suction, remember I suction and I'm using sterile technique for suctioning. And remember that if I suction, when I go in, I can end up damaging the trachea. Also, if I'm suctioning, remember that I cannot, how do I say it? If I'm suctioning, remember I can sort of like twirl the tube in a circular motion as I come up. I can do that just to catch everything on the side and everything. And remember, when I suction and I go in and I feel some sort of blockage or obstruction, or the patient starts coughing heavily, I stop. Okay, I stop at that point, because that means that there's something going on, or I'm passing the point of where the trachea is. So I don't want to suction at that part either. So I do stop at that point. Okay. Remember those tracheostomy tubes and ties you can change out, and that's part of suctioning, and that's part of tracheostomy care. Okay. Again, if anything comes out, okay, if the outer tube comes out, you put the obturator in, and then you guide that outer tube in, and this is just a way to guide it all into the patient. All right. Any questions on that? Okay, when you're suctioning, also remember to keep the patient never flat, by the way, 30 to 45 degrees, because we don't want to have them aspirate. Same thing with mechanical ventilation. If they're receiving mechanical ventilation, you'll be having them at 30 to 45 degrees. Okay. Also, oral care on your patients that have ventilation, because your mouth can get really unclean and dry, you do with chlorhexidine. Okay, what is chlorhexidine? It's like a cleaning solution, basically. It's in your mouthwash. Chlorhexidine. So you just do like a little swab with chlorhexidine. That would be okay. Okay. Going to your mechanical ventilators, there's different types of alarms that you can hear. You need to know the 2 major ones. One is a low pressure alarm. The other is a high pressure alarm. If you hear a low pressure alarm going on, the sound will be different. It's usually because there's some sort of leakage going on. Okay. It's some sort of leak. Okay. When you're hearing a high pressure alarm, it's because of blockage. And blockage could be maybe there's a lot of secretions. There's a mucus plug. Okay. They're biting on it, or there's the tubing is kinked, or they're fighting the vent. It could be any of that. That could be a high pressure alarm. Okay. Or things like pulmonary edema or pneumothorax as well. If it's low pressure alarm, it's usually due to a leakage, something got displaced or disconnected. You do need to know the differences of why you'll have high pressure and low pressure alarms. Any questions on this?
No.
No.
I don't have any question.
Okay. Also, mechanical ventilators, guys, you can have mechanical ventilators these days that are portable. So I have patients who are on ventilation who walk around like this. They will hold on to the ventilator and they will walk with the ventilator. Okay. These are your patients that they can walk around portable, right?
Mm-hmm.
All right. So that wraps up ventilation. Okay. One thing you need to know if you get a question about PEEP. Okay, PEEP is usually at 5. A PEEP just stands for positive end expiratory pressure, which means that it's the amount of air remaining within your lungs at the end of breathing. So when you inhale and expire, it's the amount of air sort of just remaining within that. which is at about 5, okay? And then it keeps the alveoli open with positive pressure at end of expiration. And basically, the PEEP you need to know is at about 5, okay? And the tidal volume is the amount of air that you're breathing in, usually given each breath, and that's about 500 milliliters for the tidal volume. Okay. Epistaxis is a nosebleed. I just put it down on here. When you're having a nosebleed, do you tilt your head back?
No, forward.
No. Yep. So you don't tilt your head back, okay? And the reason being, why would we not do that for a nosebleed, for epistaxis?
It's gonna make the blood go back.
Yes, you don't want the blood to go back. So usually sitting up and you're pinching and you're leaning forward. Okay, you're pinching the lower part of the nose to stop the bleeding. You can apply cold, okay, and cold will sort of ice to the nose and the eye area to stop the bleeding. Okay, and then if nothing is working, they can do nasal packing to apply pressure inside of the nose or the nasal balloon catheter, etc. But mostly it's leaning forward, pinching the nose, and direct pressure for about 5 to 10 minutes. If you have a deviated septum, meaning that the septum, which is a thing that divides the right and the left nose, part of the nose, you're definitely going to have breathing issues. Okay, you might have more stuffy nose, more headaches, all these different things. So again, post-op, or like if they get a surgery for a deviated septum, remember you don't want to, you want to avoid activities that increase pressure and avoid aspirin as well. Okay, what is rhinitis? Rhinitis is another word for what?
Running nose?
Yeah, runny nose, common cold, anything like that.
Common cold.
Sinusitis is mostly caused by what?
Inflammation of the sinus.
Yeah, it is, but usually can be caused by upper respiratory infection sometimes, things like that. Okay, sinusitis. Okay, in sinusitis, remember you just do a saline irrigation. You can have headaches as symptoms because it affects your sinuses, and just oral fluids, antibiotics if they need to, things like that. You already mentioned influenza, okay, which is the flu, right? And within how many hours do I need to start medications for flu if to be most effective? 24 to 48 hours, okay, after before the onset of symptoms. Usually they have to give Tamiflu, which is called oseltamivir. Okay, anything with the VIR ending is an antiviral medication, so it's given for things like influenza, okay, or herpes simplex, anything with a VIR that treats viruses. Okay, usually you want to give it. Yeah, you want to be able to give it within minimum you've had before 5 days of onset. So if you're getting Tamiflu, again, not everybody is eligible to get Tamiflu if you're high risk, and if you are having severe symptoms, you're going to have Tamiflu, which is oseltamivir is the generic name, and usually within the onset of like your symptoms, you have to take it within 48 hours of the onset of flu symptoms. So there's a window of time that you can receive this, right? Pneumonia, remember you can have fever and chills. You can have purulent sputum. What does purulent mean?
Purulent is just like the sticky in the mucus.
Yep, and it usually tells me it's infected, that they're infected. It's yellow and
infection. Okay.
Yeah, purulent. Anytime you hear the word purulent mucus, drainage, sputum, it tells me that they have
green, yellow
infection. Yes, greenish. Yep, infection. Okay, which type of patients are most likely to risk for pneumonia?
Elderly.
Or stay in bed, elderly patient.
Yes, elderly, mobility, intubated.
For immunocompromised, they were here.
Yep, immunocompromised patients. So your patients that are immunocompromised. Give me an example of a patient that's immunocompromised.
HIV.
HIV.
Yep. Cancer patients that are receiving chemotherapy. Okay.
Yes.
Or any patients that are maybe receiving things like anti-rejection drugs, like maybe they had a transplant. Okay, they're on usually immunocompromised. They're usually on medications to suppress the immune system. So they're on medication. What about patients that are on corticosteroids? Like tablets. Can they become immunocompromised?
Any reason for that?
Yeah. Yep. So they can. Yes. Because remember, corticosteroids suppress the immune system. So if you're taking
Oh
prednisone
yeah,
for a
true,
long
true,
time,
true.
right?
Yeah, that is
Immunocompromised.
true.
Yes. Okay. Very good. Yeah. Just all the, I know a lot of things that you guys know, but it's like a refresher, right? For it to come back. If I have pneumonia, I'll do a sputum culture and sensitivity testing. Okay. And things like that. ABGs, I can do blood cultures. I can do why would I do a blood culture on a patient who's pneumonia? If I suspect the infection has spread to the blood and maybe they're becoming septic. Okay. Before, I know we start a couple minutes late, so I'm going to go over to about 5 more minutes. I want to cover TB really quickly, tuberculosis, within the last couple of minutes that we have. Okay. TB, you guys, is going to be caused by something called mycobacterium. Okay, and usually you have to get a TB skin test done for employment purposes, etc. And it's known as a PPD. It's known as a 2-step PPD. So with the 2-step PPD, you have to go in the first time and they'll give you a little injection intradermally into the skin. And then you will have it read within 48 to 72 hours. And then maybe 2 or 3 weeks later, you'll have to go in for a second test. And they'll do this, they'll give you this injection again, and you'll have to have it read within 48 to 72 hours. If the induration is greater than 5 millimeters, it's positive for TB. 5. Some books will say 10 milliliters, some will say 15. But if it's greater than 5, it's usually positive for TB. Okay, and we're looking at induration, which means the raised bump. Just because there's redness does not mean anything. Redness does not mean positive. You're looking at the raised bump to say it's positive. There's 2 types of TB that we have. We have active TB and we have our latent TB. Active TB is when the patient is actively having symptoms. So what symptoms is this patient going to have? Well, they're going to have things such as night sweats. That's a big one for TB. That's how I know it's TB and not pneumonia. Okay, they're going to have night sweats. They're going to have blood or rusty colored sputum. Fatigue, weight loss. Okay, and fever that usually lasts more than 1 week, decreased appetite. So these things right here, the night sweats, the blood tinged sputum.
They will cough out blood too.
Say that again.
They will cough out blood.
Cough out blood, which is the rusty colored sputum.
Yeah. Hemoptysis, something.
Hemoptysis. Yes, very good.
Hemoptysis, yeah.
So hemoptysis would be the rusty colored sputum. That's how I know this is TB and not pneumonia. Okay, and the anorexia coming into play there. When they have latent TB, remember latent means it's sort of dormant or hidden in their system. They have no symptoms, right? Latent TB changes into active TB only when it gets triggered. So for example, maybe your immune system is working much more harder, you're more stressed, or maybe you've got another illness, maybe you're testing HIV positive, which means your immune system gets weak and now this TB sort of starts to act up. Okay, latent TB. So some people can walk around knowing that they don't know they have TB unless they take these, unless they do the PPD. Sometimes in the PPD, you're able to tell. So PPD will test you for both active TB and latent TB as well. Okay, and if they get a positive PPD, some people can get a positive skin test, the PPD. It might not be because they have TB. It might be because they received something called the BCG vaccination. Okay, if they receive the BCG vaccination, they get a false positive. Yes. So in that case, what they will do is they will be told to get a chest x-ray to see if they have an active TB. And they'll be asked to do a blood test, which is known as a quantiferon. The blood test will tell you if you actively have TB at that time. Okay. Medications-wise, I know I'm kind of running kind of quick here. Medications-wise, we're looking at the mnemonic RIPE, R-I-P-E. And R stands for rifampin. Yep. I for
Ethambutol.
Ethambutol, and
they're gonna have isoniazid.
Yep. And pyrazinamide.
I don't remember the last one.
Pyrazinamide for the P. So rifampin, isoniazid, pyrazinamide, and ethambutol. The side effects with rifampin is that it's normal to have a reddish orange.
Oh, they're right here.
Yep. Ethambutol, okay, or excuse me, isoniazid, you have increased risk of bleeding, okay, with isoniazid, and you also have increased risk of things like paresthesias, of numbness and tingling, okay? So a lot of people on isoniazid, they are told to take vitamin B6. because it helps with the numbness and tingling. Okay. In your pyrazinamide, remember they tend to experience a lot of joint pain. They're at increased risk of developing gout. Okay, and ethambutol is where I say Christmas is not Christmas anymore. They have issues differentiating between the red and the green color. They can't tell which is red and which is green if they're on this drug. And all these drugs are very hepatotoxic, which means they're harmful to what organ in your body?
Liver.
The liver. So be monitoring liver function tests for these patients is very important. How long do you think they're on these medications?
6 months.
6 to 8 months. Yes. Okay. Very quite long. Okay. And then usually TB, once they treat it, it's usually gone. But most people that have TB, what kind of precautions do we keep them on?
Airborne.
Airborne precautions. So what kind of mask?
N95.
N95.
What kind of room?
Negative pressure.
Negative pressure room. Okay.
Mhm.
Very good. Yes. Okay. Neutropenic conditions, guys. This is a completely different topic, but low number of white blood cells. So if I have low number of white blood cells, maybe some people are born with it, or it could be because, again, chemotherapy or immunosuppression. Okay. Remember, I still adhere to neutropenic precautions, which means that I'm using a mask, gloves, gown, etc. Avoiding a lot of fresh fruits and veggies, no fresh flowers, and things like that. So this is to protect you. This is to protect the patient from you because the patient has low white blood cell count. We don't need to talk about that. That is not in here. Okay, that's an ET tube inserted in somebody's mouth. What do you talk about? Pulmonary embolism. Okay, ladies, I think this basically wraps up our respiratory system. Any questions? No questions. Okay, so then I will see you guys on Thursday. So I'm going to send over our next system, which is a urinary system, but there's other stuff. So you guys can keep continuing to review on this as well. There's lots of other like minor little sides as well, okay? But I'll send over the urinary system PowerPoint, and then I'll see you guys on Thursday then.
Okay.
Alright.
Thank you.
Thank you.
No
Thank
problem.
you.
Thank you.
Thank you.
Bye-bye.
Good night. Bye.
Thank you.